Good afternoon, everyone. We're going to go ahead and get started. I want to thank you for joining me for this month's clinical update webinar. Today, we will be discussing codeine and how to interpret results. My name is Dr. Kristin Hillman, and I am a member of the clinical team here at Aegis. Let's go ahead and get started. So today we will discuss codeine metabolism. We'll discuss which metabolites are expected and why metabolites may be present or absent. We'll discuss the period of detection in both oral fluid and urine specimens. We'll examine other potential causes for positive codeine results. And lastly, we will look at all of these items through the lens of Aegis lab reports. So let's begin by breaking down codeine metabolism. Codeine is metabolized to norcodeine, morphine, and hydrocodone, which are then further metabolized to norhydrocodone, hydromorphone, and dihydrocodeine. The drug names that are in boxes on the screen are not only metabolites, but they're also drugs that could be prescribed individually. We'll talk about these different metabolic pathways and discuss why some metabolites may or may not be present in every sample. Norcodeine, the nor metabolite of codeine, is a unique biomarker that results from CYP3A4 metabolism of codeine after ingestion. Although norcodeine possesses weak opioid activity, it is not likely to contribute to the overall analgesic effect. The same is true for the nor-metabolite of hydrocodone, norhydrocodone. CYP3A4 metabolism is subject to both induction and inhibition by many drug-drug and drug-food interactions, potentially altering the nor-metabolite concentrations. Drugs that inhibit or induce the CYP3A4 route of metabolism can modify the effects of opioids by increasing or decreasing the metabolite and parent concentrations, altering either the analgesic effects or causing adverse drug effects such as sedation, respiratory depression, and/or death. On the other side of the equation, morphine, hydrocodone, hydromorphone, and dihydrocodeine are all pharmacologically active metabolites of codeine, two of which are products of the CYP2D6 metabolism. Although the CYP2D6 enzyme cannot be induced, it is subject to inhibition by a host of medications and may also become saturated. CYP2D6 also exhibits a tremendous amount of genetic variability. The clinical significance of CYP2D6 inhibition is variable and can bring about either an increase in active parent drug or a decrease in the active metabolites, altering the analgesic effects or causing adverse drug effects. We'll examine the minor metabolic pathway of codeine next. And though it would be helpful for interpretation, parent to metabolite ratios do not allow for the identification of the initial opioid ingested. There is, however, one notable exception for codeine. The metabolism of codeine to hydrocodone in urine will typically have a concentration of less than 5% of the codeine concentration. The enzymes responsible for these metabolic pathways have not been identified, and the metabolism may not occur in all patients. The laboratory report example in this slide demonstrates a total hydrocodone concentration, which includes the hydrocodone plus its direct metabolites, norhydrocodone, which is 3% of the total codeine concentration, which includes codeine plus its direct metabolites. So it includes codeine, norcodeine, and morphine. Since this concentration is 3% and it's less than the 5% of the codeine which defines this minor metabolic pathway, the hydrocodone is most likely resulting from codeine metabolism and is not a separate ingestion. The lab report in this slide demonstrates a total hydrocodone concentration, which is 77% of the total codeine concentration. This concentration is greater than the 5% of the codeine, which defines this hydrocodone as a separate ingestion, as it is indicated in the medication compliance box at the top. This section of an Aegis report shows the results of an oral fluid specimen. Here you can see that parent drug codeine has a quantitation of 17 nanograms per mil, and there are two metabolites present, the dihydrocodeine and the hydrocodone, each with reported amounts that are less than the parent drug. Many times, oral fluid results reflect parent drug concentrations that exceed metabolite concentrations, like it does in the sample. But this is not always the case. It is possible to see more metabolite than parent. Lastly, how long do we expect to see results in oral fluid after ingestion? Codeine and most drugs in oral fluid typically have a period of detection of up to about 48 hours. Results from urine specimens typically have concentrations that are 10 times higher than an oral fluid. This Aegis report shows the results from a urine specimen with a positive parent codeine and 4 of the 6 possible metabolites. And typically, metabolite concentrations exceed parent drug concentrations. However, this is not always the case, as shown in this sample. Metabolite ratios should not be used to establish drug compliance. This report is just one example of what an expected result from codeine ingestion in a urine specimen may look like, as it certainly can vary. It is possible to observe parent codeine in urine in the absence of metabolites. The likelihood of such a finding may be increased in patients with impaired metabolism due to genetic or drug-food interactions. Or finding parent-only codeine may suggest recent oral drug ingestion. The concentrations in these cases should typically be low, as indicated in this slide, where it's 146 nanograms per ml. Additionally, when concentrations are very low, it's difficult to assess if the metabolite may have fallen just below the threshold, and as a result, are reported as negative. On the other hand, when parent-only results are significantly higher, here you can see it's greater than 20,000 nanograms per ml, further patient assessment to rule out binging or abuse is warranted. Addition of a drug to the sample post-collection or after sample substitution in an effort to appear adherent with prescribed therapy may often result in high parent drug concentrations in urine with no metabolites present. But the clinician should always take the laboratory report into consideration along with the patient's medication use history and clinical presentation. The result for codeine here includes a greater than sign, and this is signifying what is called an upper limit of quantitation. This means that the concentration of codeine above 20,000 nanograms per ml is not available for us to review. Concentrations that are above the upper limit of quantitation may be less accurate as they are outside the limit of linearity of our instrumentation. For this reason, this information is not reported, nor would it be likely to provide much useful information clinically. Every drug is assigned an upper limit of quantitation in definitive testing. Patient underreporting and denial of non-prescribed or illicit drug use are common. However, there are instances when an unexpected positive result has a rational explanation that does not involve extracurricular drug use. It is important to explore all potential sources before enforcing disciplinary action. Codeine is present in pharmaceutical products, including Tylenol number 3 and number 4, Fioricet with codeine, paregoric, tincture of opium, and belladonna and opium, and will subsequently be present on prescription drug monitoring programs since codeine is a controlled substance. In some states, over-the-counter medications can contain codeine mixed with cough suppressants like dextromethorphan and/or promethazine. Codeine may also be present after the use of heroin, although the most prevalent metabolite for heroin ingestion is morphine. Lastly, we must discuss poppy seed ingestion. Both codeine and morphine may be present in poppy seeds, which can be found in many food products such as breads, bagels, salad dressings, and even some teas. Historically, we assume to expect only morphine in urine following poppy seed ingestion, as it has been the subject of numerous small studies. Codeine, however, may also be detected, though it tends to appear at significantly lower levels and typically would not be present in the absence of morphine. Studies have shown that after poppy seeds are consumed, small amounts of morphine and/or codeine may be present in oral fluid for 2 to 4 hours and in urine for up to 48 hours. One notable exception exists in the literature with the case of a subject who consumed bread containing a poppy seed variety with an unusually high codeine content. The resultant urine specimen contained several times more codeine than morphine, suggesting ingestion of codeine alone. So the best advice for patients undergoing drug testing is to completely avoid poppy seed containing products. These are the references listed for today's talk. And although we focused on codeine today, we really were able to address opioid metabolism, minor metabolism, differences between urine and oral fluid specimens, no metabolite scenarios, and some incidental exposure examples. If you have questions specific to codeine or any general questions, please feel free to call or email the clinical team using the information at the bottom of this slide. Thank you for your time this afternoon, and I hope you have a great rest of your day.